Got it. Okay, good morning. So it is a pleasure to make this presentation today. And in fact, this presentation was registered the 14th of September because, as you know, I am a medical doctor, and this morning I'm doing the transmission in my intensive care unit. That's why it was recorded, but I will be present for question after this recorded presentation. So the title of this presentation is Identification of Sepsis up to 72 hours in advance. And it will be a presentation of a new biomarker of sepsis, which name is pancreatic stone protein. First of all, just introduction about what is sepsis. I'm sure you know what is sepsis, but I'm going to give you some numbers. Sepsis is a very important disease worldwide with about 50 million cases every year and with about 11 million deaths every year. And this is the second leading cause of death worldwide and the first cause of death among children. So this is a very important disease. Yes. And what is nosocomial infection and sepsis? This is infection catch at the hospital, and in Europe and in Switzerland, there is 5 to 8% of the patients hospitalized who would have an infection occurred in the hospital. This number is about 10% in the US. More than 50% of patients in the intensive care unit will have an acquired infection, and worldwide it represents, this is estimate, about 1.4 million infection occurred during a hospital stay. In Switzerland, it means about 2,000 to 6,000 deaths per year, and in the US, 100,000 deaths. What are the causes of nosocomial infection and sepsis? First of all, it will be the hand hygiene, and a very important point, the antimicrobial resistance. And what is the cause of antimicrobial resistance? It is the overuse of unnecessary antibiotics and of broad spectrum antibiotics. And is it an important problem? Yes, it is an important problem. This is the result of a study published this year in January in the Lancet. And this study says that about 5 million people are dying every year because of bacterial antimicrobial resistance, and really 1.23 million of deaths are attributed to antimicrobial resistance. And the forecasts are terrific because we thought that in 2050, about 10 million people are going to die because of antimicrobial resistance. So it will be quite the same number of sepsis nowadays. And that's why the WHO and the G7 health minister propose or says that antimicrobial resistance are a major threat for human health. And it will be an absolute priority. So the question is to give or not to give antibiotics, because a way to reduce the current 11 million deaths of sepsis is to give timely and adequate antibiotics, but a way to reduce the future 10 million deaths of AMR is not to give unnecessary antibiotics. So the question is to give or not to give antibiotics. What are the criteria in 2022 to start antibiotics, not to start antibiotics, or to stop antibiotics? So a very small introduction about what is sepsis. The definition of sepsis. Sepsis is a dysregulated reaction of the body to an infection. So some people are going to have an infection, and some of them, not all, are going to have a dysregulated reaction of the body, and it will be a sepsis. How are we going to do the diagnosis in 2022? Both for infection and for the sepsis, there is only clinical evaluation to have the diagnostic of infection of sepsis. Just the clinical evaluation, nothing else, and just the suspicion of infection, suspicion of sepsis, and this is a criteria to start antibiotics nowadays. It is just the probability, and if the likelihood is thought to be high, we are going to give antibiotics. So we are going to give antibiotics very easily. And this is the last guidelines. This is the guidelines of October 2021. And so the international guidelines says nowadays that antibiotics are to be started only based on clinical suspicion. So this way of doing, does it work? No, it doesn't really work because there is only 30% of definite adequate blood spectrum antibiotic therapy. All the rest are situations where we are going to give antibiotics for possible or probable sepsis or infection. So because it doesn't work, do we need something else to help us to start antibiotics? For example, biomarker. In fact, no, and this is the reason why there is no biomarker in the international guidelines, not because the biomarker are not working, but as you have understood, as the current guideline says to start antibiotic if there is any likelihood. So biomarker will be not better just of clinical suspicion. And we are going to do biomarker because there is clinical suspicion, but we have to give antibiotics already because there is clinical suspicion. So biomarker have no added value to start antibiotics. And this is the reason why biomarker are not included in the international guidelines. But sorry, just a presentation of a survey we did 2 years ago. I have asked my colleague how they are going to detect sepsis. So it was in 2020. And they say they are using a mix of the definition already used. This is just to highlight that the diagnosis of sepsis is not really clear and only based of a mix of clinical evaluation, but with no perfect tool. I've asked my colleague which biomarkers are using to detect bacterial infections. The answer was procalcitonin. The answer is good, I will say, but maybe as you know, procalcitonin are not belonging to the international guidelines because, as I told you before, there is no added value of procalcitonin. Even the sensibility is 77% and the specificity is 79%. So procalcitonin is not using and not recommended in the current international guidelines because there is no added value. But as I told you before, even there is no added value, it works. This is an interesting study showing that CRP, lactate, PCT, troponin, BNP, creatine, urea, and pancreatic stone protein are working to detect sepsis in advance, but with no added value compared to clinical evaluation. So, as I told you before, a biomarker had no added value when there is a clinical suspicion of sepsis, but does it work before symptoms and clinical suspicion? The question is, it is possible to use a biomarker for pre-symptomatic diagnosis of sepsis. For example, it will be to give alert of nosocomial infection before clinical suspicion. As I told you before, there is a high risk of infection occurred in the hospital. So the idea is to use biomarker to detect in advance, even before symptoms, a future infection and sepsis. And there is different studies to detect which biomarker could or which score could help in the diagnosis of sepsis before clinical symptoms. And I'm going to show you the results of pancreatic stone protein, and because you are going to see that pancreatic stone protein is a better marker to detect sepsis in advance. What is pancreatic stone protein? I have no time to go into much details, but PSP is a 16 kilodalton lectin protein produced mostly by the pancreas. We have some idea of the physiopathology of pancreatic stone protein, not definitive understanding of the function of PSP, but already some good idea of the physiopathology of this protein. But I have no time to go into much details. But what is important, there is already quite a lot of clinical studies. This is not just an esoteric new biomarker. There is already 13 clinical studies about quite 4,000 patients. There is already a prospective multicenter study, a meta-analysis, all published in Critical Care last year. And there is, for example, this year in the Journal of Clinical Medicine, a review of 23 prospective studies, just to highlight there is quite already a lot of clinical studies on this biomarker. I'm going to present in more detail one study highlighted the way of pre-symptomatic diagnosis of nosocomial sepsis based on biomarkers. This is a study done in Zurich, Switzerland, in a burn center, and there was 90 patients included. And as you know, of course, patients with burn injury are at high risk of nosocomial infection. On the graph here, you have the CRP. You can see that in green, there is 31 patients with no infection, and CRP level is not moving during the stay. White blood cell is quite the same. Some patients, 13, have had infection. There is some, I will say, moving of CRP, the same with white blood cell. Some patients, 39, have had sepsis, and CRP has quite higher level, but there is not a big variation the day of sepsis. The day of sepsis is here, the day of event. So CRP is not increasing a lot before the sepsis, and it was the same with a septic shock. The CRP increased, but the day after the sepsis. And we can see here on the right side, it is quite the same with white blood cell. These two biomarkers are not able to predict sepsis in advance. In the next graph, you will have on the left side the PSP, pancreatic stone protein, on the right side the PCT. And what is very interesting to see, this is that with sepsis, PSP is rising already 3 days in advance. It was not the case with PCT. And with patients with septic shock, PSP is really increasing a lot the day before the sepsis. And with PCT, we can see that PCT increase only the day before and after the event. That's why the hypothesis of pre-symptomatic diagnosis of sepsis by PSP was proposed. And based on that study, a multi-center study was done in Europe for 14 studies, 250 patients in the intensive care unit, and daily routine PSP monitoring was done. And we can see in that graph that PSP was increasing before sepsis, like in the burn center study. It was not really the case with PCT, and you can see the standard deviation are very high here. It is not the case with PSP, and CRP as well is not as good as PSP to predict sepsis in advance. That's why the author concludes that PSP could be a very interesting biomarker for early detection of sepsis before the appearance of signs and symptoms. This is what we call the pre-symptomatic diagnosis of nosocomial sepsis. This is a case report. I have not a lot of time to go too much in detail of this case, but this is a real case in my private clinic, in my intensive care unit, a case of postoperative peritonitis. And it was really, really useful to test PSP every day. And we have had a very, very good experience that PSP predict complication and help us to do CT scan, to go back to the operation theater in case of new peritonitis in that kind of patient. And this patient, there is a very, very good highlight of the using of PSP compared to other biomarkers to predict sepsis in advance. This case report will be published, but I have no time to go too much in details. So based on that studies and based on this clinical experience, we propose to use PSP as a daily routine measurement in patients hospitalized in the intensive care unit or maybe in the ward. Even for patients without suspected infection, we propose to do a clinical evaluation, of course, and to dose biomarker every day. And if there is an increase of PSP, we can start empirical antibiotics based on good reason to do that. A question of money, of course, it costs to do this test, but it costs to have nosocomial infection at the hospital. In Switzerland, this is Swiss numbers. The cost of nosocomial infection is about 750 million Swiss francs. But on the cost of a daily PSP testing to each patient every day in Switzerland, nobody are going to do that, but just to have the highest number as possible, the cost will be about 250 million Swiss francs. So the save for the healthcare system will be around 300 to 500 million of Swiss francs. This, of course, these numbers are not totally accurate, but this is a way just to show that with a PSP test every day, we are going to save money and not to spend more money. Okay, this was the criteria to start antibiotics. But what are the criteria in 2022 not to start antibiotics? In fact, there is no real criteria. The criteria will be there is no sepsis or not likelihood of infection. So there is not a clear criteria not to start antibiotics in 2022. That's why a lot of antibiotics are start if there is a clinical suspicion of sepsis. And we are, as a medical doctor, we love or we like to start antibiotics because we are afraid not to start, because if you are not starting antibiotics, it could be very dangerous for the patient. So that's why antibiotics are given quite easily. But of course, if you are going to give too much antibiotics, the risk of antimicrobial resistance will be higher, but not for the patient, but for a public health problem. And for this reason, we are giving antibiotics very, very often. This is Swiss numbers, once again, but I'm sure in Sweden it will be quite the same. We can see that about 1/3 of the patients hospitalized have antibiotics, 60% to treat infection, 40% for prophylaxis. This is at the hospital, but in Switzerland, 80% of the antibiotics are used outside the hospital. So there is a large use of antibiotics in Switzerland, in Europe, in Switzerland, in Sweden, and I'm sure all over the world. So, sorry, this is the same diagnostic slide. So before the antimicrobial resistance, it was easier and safer to give antibiotics than not to give them. But now, with antimicrobial resistance, we need a tool to rule out infection and sepsis in less than 1 hour. So which tool we can use? Maybe a biomarker. And we propose this sepsis AMR matrix. It is very easy and very obvious, I will say. Patient with sepsis, we are going to test a biomarker. If the biomarker is positive, we are going to give antibiotics. This is okay. This is true positive. And we will have true negative as well. But if there is sepsis, but the biomarker is negative, and we are not going to give antibiotics, there is false negative. It will be not a good idea because it could be very dangerous for the patient. And we could have false positive. So we are going to give antibiotics for no reason, and it will be not good for the public health system. So we have to find the biomarker, or maybe a combination of biomarker with a very good negative predictive value to have as less as possible as false negative. So which biomarker can we use to fulfill this sepsis AMR matrix? Sorry. As I told you, this biomarker must have a very good negative predictive value, even a good positive predicting value to prevent AMR. But the most important, as I told you, is a negative predicting value. This is number extract for different studies. And we can say for PSP, pancreatic stone protein, in different cutoff, that the negative predicting value is about 90%. And this is better than compared to other biomarker. And we can see here, for example, in that study, with a PSP level lower than 168. In that study, it was quite the same number. The negative predicting value is 87%, but for PCT with normal values, negative predicting value is only 70%. Once again, a question of money. This is a study published this summer in a Health Economic Review journal, showing that if PSP specificity is 80% in the US, the national saving will be 7 billion, not million, but 7 billion of US dollar using PSP at a price of 52 US dollar. In the US, they are going to save a lot of money. So we propose to use PSP not to predict sepsis, but to rule out sepsis. And this is a new way to use biomarker because, as I told you before, there is no added value to diagnose sepsis with biomarker, but we really thought there is an adding value of biomarker to rule out infection and not to start antibiotic based on a very good negative predicting value depending on certain cutoff. And this is the sepsis 3 definition figure, and we have added biomarker beside the clinical evaluation to decide in this tree to decide when to start or not to start antibiotics. So I present you when to start antibiotics in 2022, when not to start antibiotics, and this is the criteria to stop antibiotics. As the guideline says, we have to do a daily assessment for de-escalation of antibiotics. We have to use as short as possible antibiotics, and we have to stop antibiotics based on clinical evaluation on procalcitonin, because there is study on procalcitonin to stop antibiotics. There is study on the way to test if PSP could be a very good marker to decide to stop antibiotics. I'm quite confident, based on some preliminary results, that PSP could work in this indication as well. In conclusion, to answer the question to give or not to give antibiotics, the answer will be to give antibiotics if the likelihood of infection is thought to be high, and not to give antibiotics if a biomarker with a good negative predicting value, like PSP and CRP, is low. Secondly, to give antibiotics before the likelihood infection is thought if a routine daily biomarker like PSP alerts for pre-symptomatic diagnosis of nosocomial sepsis, and not to give antibiotics prophylactically in hospitalized patients, and to stop antibiotic as soon as possible based on clinical evaluation on a biomarker like procalcitonin. And this conclusion is summarized in this slide, showing that before sepsis, for patients hospitalized, we have to do a pre-sepsis daily assessment or the pre-symptomatic diagnosis of nosocomial sepsis based on PSP, and not to do antibiotic prophylaxis. And this way of doing could save a lot of money of the healthcare system. In case of suspicion of sepsis, we have to apply the clinical evaluation and this sepsis AMR matrix as proposed before. And based on the result of probably the combination of two biomarkers like PSP and CRP, if this combination is low, this is a good reason not to give antibiotics. And we propose to use biomarker not to help us to decide to start antibiotics, but to help us to decide not to start antibiotics. And this way of doing in the US show that we could save a lot of money for the healthcare system. And after the sepsis, what we call the post-sepsis daily assessment or the de-escalation of antibiotics is based on clinical evaluation on biomarker as well. So we propose to use PSP for pre-symptomatic diagnosis, to rule out infection, or to decide to de-escalate antibiotics. Well, so I hope this presentation was interesting for you. I'm open to questions. Now I will be back live with you. So if you have any questions, thank you very much.